We are back once again with yet another CME on medicinal adherence. This is the eighth episode of our CME series that goes all year long. So, without any further ado, I would like to introduce our two distinguished guests, Dr. Shambo Samajdar and Dr. Santanu Tripathi, who have been there with us all along our journey. So this is the eighth edition. You all have seen our last edition, the seventh edition, which was we had the prestige and the very good luck of having it with the Geriatric Society of India. It was a rather extended session. The link is available on both YouTube and Facebook. So without any further ado, I would like to welcome you all to today's CME titled Treatment Adherence in Diabetes Management, the single most important attribute to optimum outcomes. And I would like to invite Dr. Santanu Tripathi for a quick few words, after which Dr. Samajdar will begin the first session of the day. Thank you.
So, thank you very much. And now the stage is set for yet another evening on our series of adherence in healthcare. And today it's a very important session because we are discussing the issue of adherence in a disease that is diabetes mellitus. We all know how very important this is from the perspective of India. India has been held as the diabetes capital of the world almost, and then we have a huge number of diabetes patients. I think it is somewhere around 70 million or so, and in another maybe couple of decades, it's going to be exceeding 120 millions. It is predicted. What is said that out of every patient of diabetes diagnosed, there is always another patient who is not diagnosed, undiagnosed. So out of every two patients, one is diagnosed and one is not. Again, out of every two diagnosed patients, okay, one is having more or less acceptable level of compliance and another is not having adequate compliance. That means 50% of all diagnosed diabetes patients, there is a problem with adherence, treatment adherence. So it's such a huge issue. And as we all know, if the treatment is not followed by the patient, nobody can expect any kind of desired outcome. So we need to diagnose a disease, we need to give the right treatment, and then the patient has to also follow the advice of the doctor. Then only we can expect the desired outcome. And that's something which are very, very distant goal as of today even. And not just in India, throughout the world, this is the situation. Today, different aspects of this area will be discussed by experts. To start with, before we go further, I'll request Dr. Shambo to just briefly tell us the agenda of today's this evening's discussion, the different subtopics that we are going to discuss. Over to Dr. Shambo Samajdar.
Thank you, sir. So today we will discuss first of all regarding the obesity management and the adherence issue, and then we will move to one important aspect, that is the different phenotypes of type 2 diabetes and how we should approach, and also how we can focus on the adherence among those different phenotypes of diabetes. Then the third topic will be on the insulin, when to initiate insulin and how to titrate the dose of insulin, specifically in the context where there is a inertia against insulin initiation, and also in terms of insulin titration. So there is some fear among the physicians, fear among the patient and their caregivers. So we will discuss about that. And then finally, we will have a thorough discussion on the overall adherence issue, which is very important for all chronic diseases, and specifically while talking about diabetes, it is also very important to give emphasis on adherence, and that will be taught by Professor Santanu Kumar Tripathi sir at the end. So with this is the agenda today, and shall I proceed to the first topic, sir, with your permission? Okay, so good evening, everyone. It is a very important area when we are talking about diabetes management, the obesity. So, as Sir has already mentioned, that India is going to be the diabetes capital of world, and we don't know whether we also face the epidemic of obesity in Indian context. So it is a very important area we need to give emphasis. And now I just want to start with one real life case that I had faced 2 days back. A 70-year-old Mr. HD who had type 2 diabetes, hypertension, CKD, interstitial lung disease, and hyperuricemia. This is the drug chart, medication chart, which he was on. And from my prescription, it was August 2020. So we can see here the dose of glargine insulin needed, then the anti-diabetes agent like linagliptin, repaglinide 1 milligram twice daily, along with the antihypertensive agents like amlodipine full dose 10 milligram, nebivolol, telmisartan full dose 80 milligram, aprozole 25 milligram thrice daily, Gitanix, that is 2.5 milligram. These all are the antihypertensive medications that was taken by him. Along with that, atorvastatin, clopidogrel for BHP, he was on sildosin, febuxostat 40 milligram, along with the different drugs prescribed by the pulmonologist. So there is a huge issue of compliance and adherence in this particular patient. And it was often seen that in my clinics, in recurrent visits, the blood pressure was little bit in the higher sides. Diabetes was almost controlled, well controlled, but the blood pressure was very much uncontrolled with lots of drugs we can see here. But what happened, just 3 days back, I had a telephonic consultation with this particular gentleman. He is now on only a fixed dose combination of nebivolol 5 milligram with S-amlodipine 2.5 milligram, a fixed dose combination with the atorvastatin clopidogrel fixed dose combination with anti-BHP medicine sildosin and febuxostat, along with the inhalational agents and antifibrotic therapy as prescribed by the pulmonologist. So no anti-diabetes medicine. Now the anti-hypertensive medicines, which is, we can see how much he was on and now how much reduced it is. Now the question arises, what is the magic behind that? So just 1 year, but how this happened? So this is the report on August 2020. His creatinine was around 1.9. Urine albumin creatinine ratio is in the macroalbuminuria range. HbA1c was 7.6%. And as the blood pressure was not that much controlled, it was also sometimes some of the nephrologist had also advised him to plan for dialysis in future. So what happened? The latest report, August 2021, now we can see the creatinine value is 0.8 milligram per dl, fasting 94, pp 147 milligram per dl. So what is the magic behind this? That you can see in this slide. In the August 2020, when he had visited my clinic, the body weight was 89 kg. But now the body weight is 61.5 kg. So this reduction of this the body weight actually reverse lots of diseases. So now with this body weight for last 2 to 3 months, he is not on any anti-diabetes medications. He had reduced all the antihypertensive medications, only one drug, one fixed dose combination he was on. So the cause behind this is not the lifestyle modification, unfortunately, but he had a severe COVID-19 pneumonia, and he had to admit in one hospital in the city in 7th May 2021. And there is again in the June, he had developed a post-COVID-19 sequel with Clostridium difficile infection. So this infection actually is the responsible thing to reduce his body weight, but the reduction in the body weight give indirectly lots of benefits. We don't want this type of benefit at all. By some life-threatening condition, we will get some benefit. It is not at all required. But this is a real life situation that can happen. The only thing needs to be given emphasized is the reduction is in body weight is very, very important for reversal of different types of disease. So this was the first interventional trial published in NEGM, which shows the reduction in the incidence of type 2 diabetes by the lifestyle modification. The loss in 7% of their body weight demonstrated with a reduction in the incidence of type 2 diabetes by 58%. So we can see here it is much more better than the metformin arm also. So this is the importance of reduction of body weight, and we need to give emphasis on that. So in a world where food supplies are intermittent, the ability to restore energy in excess of what is required for immediate use is essential for survival. So we have fat cells that reside within the widely distributed adipose tissue depots. They are adapted to store excess energy as triglycerides, and they give it to release the stored energy as free fatty acid when we need that. So this physiologic system orchestrated through different endocrine and neuronal pathways, and this actually permits humans to survive starvation for as long as several months. However, in the presence of this nutritional abundance and a sedentary lifestyle, and influenced importantly by different genetic modifications, this system increase the adipose energy stores and produce different adverse health consequences. So, and development of obesity. So obesity means a state of excess adipose tissue mass. We know this chart very well, but for Indian population, which is important, the normal BMI is between 18 to 22.9, overweight means 23 to 24.9, and obesity means more than 25 kg per meter square. But here it is also important to give emphasis on the waist circumference. So for a critical value, that is 90 centimeter for men, and women it is 80 centimeter. But for maximum of our population, it is also important to give emphasis on this waist circumference, that is 78 centimeter for men, and for women it is 72 centimeter, because any person with waist circumference above these levels should avoid gaining weight and maintain the physical activity to avoid acquiring any of the cardiovascular risk factors. So this is a very important threshold, 78 and 72. But for those who have more than 90 centimeter or 80 centimeter in case of female, they should seek medical help so that the obesity related risk factors could be investigated and managed properly. So this is the waist hip ratio, that is also very important to consider, 0.9 for women and 1 in case of men. More than 1 is in case of male. So this is a beautiful diagram taken from the textbook of Harrison, that is the energy intake and expenditure. So this balance is very important, and appetite is influenced by many factors that are integrated by brain, most importantly within the hypothalamus. the signals that impinge on the hypothalamic center that include neural different afferents, hormones, different metabolites. The vagal inputs are particularly important, and bringing informations from different viscera such as gut or some other viscera. There is also very important influence from the hormonal signals like leptin, insulin, cortisol, gut peptides, like that. Ghrelin is also important, which is made in the stomach and stimulates feeding. There are some peptide YY and cholecystokinin, which is made in the small intestine and signal to the brain through the direct action on the hypothalamic control centers, or sometimes via the vagus nerves. Metabolites like glucose can influence appetite, as seen by the effect of hypoglycemia to induce hunger. So another important thing is that the basal metabolic rate, here we can see the energy expenditure generally by resting or basal metabolic rate. Number two, the energy cost of metabolizing and storing food. Number three is the thermic effect of exercise. And number four is the adaptive thermogenesis, which varies in response to long-term caloric intake and generally rise by increase in intake. But the important thing to note is that the basal metabolic rate accounts for the 70% of daily expenditure, whereas the active physical activity contributes only 5 to 10%. Thus, a significant component of the daily energy consumption is fixed. So that is why we need to give more stress how we can reduce body weight. We cannot change that 70% portion. We have to do work with that further 30%. Most of the thing is that at around 10 to 20% portion. So here we can see the concept of adipostat. So this particular scheme depicts a situation in which the signal that is normally considered to be the leptin, already we had discussed about leptin, that indicates a level of body energy reserves lower than those required by the adipostat set point, which results in regulation of food intake either positively and thermogenesis negatively to restore the desired level. So there is a continued interest in this particular concept of a body weight set point. This idea is supported by physiologic mechanisms centered around a sensing system in the adipose tissue that reflects the fat stores and a receptor called as adipostat. So there are concepts. It can be a peripheral adipostat present in the adipose tissue, or it can be a central adipostat which can be present in the hypothalamus. So when fat stores are depleted, this adipostat signal is low, and the hypothalamus responds by stimulating hunger and decreasing energy expenditure to conserve energy. Conversely, when fat stores are abundant, the signal is increased and the hypothalamus responds by decreasing the hunger and increasing the energy expenditure. So for that, it is very important how much calorie we should prescribe, how much we should how much exercise we should prescribe, because it will not done in one day. We need to give time for those patients who came to us for management of obesity. So management of obesity, first of all, most important thing is the history taking. So history taking is one of the most important part, because the management of obesity starts from history taking. I will tell you why this is important. Thorough clinical examination and lab investigations to rule out obesity associated diseases. Motivational program, help of psychologist is very important. Diet and exercise, pharmacotherapy and surgery. So this is why the history is important, because while taking the history, we are starting our counseling, that how we should approach obesity. So what factors contribute to the patient's obesity? How is the obesity affecting the patient's health? What is the patient's level of risk from obesity? What are the patient's goals and expectations? Is the patient motivated to begin a weight management program, or what kind of help does the patient need? So this type of question also help us to start the management from the history taking itself. So we need to give one specific lifestyle history named as Queen's lifestyle history. Need to take proper history on nutrition status, physical activity level, tobacco or alcohol use, sleep habits, stress management, and healthy relationships. And with that also we can start giving them some specific recommendation to change their bad habits. Again, this is a cardiovascular health or goal metrics. So this way we also can, when we are taking some history like what is your diet pattern, so if we just tell your health diet score components is poor, so with that also only we can start counseling our patients. So this health metrics is very important, and if we can use this while seeing our obesity patient, so that can give a very good response in terms of obesity management. Next, we need to give also emphasize to look at the comorbidities. As we are talking about diabetes metabolic syndrome is a very common comorbidity present with our obese patient, but we should not forget to look other comorbidities also, whether the patient has any colon cancer or osteoarthritis, hypogonadism, or having some depression. This all thing we need to consider. And as a student of clinical pharmacology, it is also important to give emphasize on the iatrogenic cause of obesity. What are the drugs the patient is on which can aggravate this obesity? So whether the deprescribing those drugs can help our patients to have less weight gain. So this is a closed loop cycle of diabetes and obesity. So weight gain in persons with family history of type 2 diabetes, which increase the need of glucose as the body weight increasing. So beta cell secretes more insulin, but unfortunately these patients have insulin resistance at the level of liver, muscle and fat. So that also lead to more insulin secretion to counter that glucose increase. So ultimately there will be more insulin level, and this cycle will go on and on. This insulin hyperinsulinemia will be responsible to develop hypertension, and also they are going to destruct beta cell, and ultimately the type 2 diabetes will be moving on, the pathophysiology will be going on and on. So the patient's readiness to change is very important while seeing the patient. So readiness can be viewed as the balance of two opposing force. Number one, the motivation or the patient's desire to change, or if there is any resistance or the patient's resistance to change. And it is very important to recommend that person with obesity, we should use this terminology rather than the obese person. So how we should talk with our patient, that is also very critical. That will define whether the patient, from the patient's level, will get some resistance or not. So we should be very much patient centered, non-judgmental language that we should use, because that fosters the collaboration between patients and providers, including the pupil. So we should use very judiciously this type of language. Very important point, we should have some accommodations, whether we can check the body weight in a privacy. So that is also very important. And regarding the diet, physical activity and behavioral therapy, we should try to achieve a goal of more than 5% weight loss. We should not be very much ambitious from the beginning, as already we discussed about the concept of adipostat. So start with a goal of more than 5% weight loss, maybe at around 7% weight loss we can try. So we appreciate there will be greater benefits with more weight loss, but we should start with slow, and then we can go further. So high frequency of counseling, behavioral therapy is very important, and then we should have a focus on the dietary change, intake, and more output, increase the physical activity, and also together we should use behavioral strategies to protect this dietary change and physical activity to increase the adherence to the dietary change and physical activity. We need to maintain a 500 to 750 kilocalorie per day energy deficit in our patients. So what is important, we should be very much individualized with their preference, patient's preference, motivation level, life circumstances, and other medical status also. These all should be taken care of, and the dietary recommendation should be patient specific. So this is a guideline from 2030 obesity guideline. So there, if we can reduce 3% weight, so there is a decreased risk of developing diabetes. If it is 5%, so apart from that, there will be improvement in the blood glucose level, blood pressure level, HDL and triglyceride value. And if we decrease it much, so there will be more benefit. So what is adherence to long-term therapy, which is very much appropriate with this type of diseases, lifestyle diseases like obesity? So definition of adherence means the extent to which a person's behavior of taking medications, following a diet, or executing the lifestyle changes corresponds with a agreed recommendations from a healthcare provider. So there should be a agreed recommendation, and it is important to consider adherence is not equal to compliance. In compliance, there is no active participation from the patient side, but in adherence, we should have active participation from the patient side. So in case of this type of therapy like obesity management, we should act as a coach. The main player who will play in the field, that is the patient. So patient should be the active partner with health professionals in their own care, and it should have a multidisciplinary management. So there is a role of dietitian, psychologist, exercise physiologist, a physician. If all fails, then we have metabolic surgeon. So diet therapy, which is very important, so we should initiate it with a reduction of 500 to 1000 kilocalorie per day compared with the patient's habitual diet, and we should reduce the carbohydrate intake, specifically when the patients are suffering from type 2 diabetes. We should make a MUFA a little bit higher at around 14% or 16% like that, and total fat should be less than 35%, saturated fat should be less than 7%, and the protein intake should be more, and it is at around 1 to 1.5 gram per kg body weight we should prescribe protein. So more whole grains, fruits, vegetables, and dietary fiber should be there. And as already we told about the importance of omega-3 fatty acids, so we need to reduce sodium, we need to take care of their metabolic health, the hypertension things. And also it is important to increase the fiber level. Generally it is important for 1000 kilo, if I am prescribing a 1000 kilocalorie diet, there should be at around 15 grams of fiber, and generally we prescribe at around 30 grams of fibers in our patient. So this is the carbohydrate cycle and cardiovascular disease, the cycle we can see. If we eat more glucose, so what happened? The pancreas will produce more insulin, but as there is more insulin, and there is again a presence of insulin resistance, so ultimately insulin will not act properly, or even if insulin is acting properly, then it will promote lipogenesis, and there will be more triglyceride level, more HDL, more BP, and that contribute to the insulin resistance. And if it is more insulin resistance, again there will be more hyperinsulinemia. So the cycle will go on and on. And this is a very famous cartoon. We can know the effect of positive calorie balance. So if there is more calorie balance, more money in our pocket, so what happened? The liver will act taking care of that. So more liver fat will be there. So more liver fat means that will contributes more VLDL level and triglyceride level, and that also accumulate in the islet cells, more triglyceride level in that islet cells. And what happened? The insulin response to ingested glucose will be decreased, and there will be the pancreas cycles will be altered. So ultimately the pancreas will try to increase the insulin level, but that will not controlled by those insulin, as there will be a development of insulin resistance. So more postprandial glucose level, and that cause increase in plasma glucose. again what happened, as there is a insulin resistance level at the level of liver, so there will be a resistance to insulin suppression of glucose production, so more basal insulin secretion. So two things will happen: the basal insulin will be secreted more, and the postprandial glycemic excursion will be there. So one thing we can correct, that is the positive calorie balance. So our pocket should be emptied rather in a negative balance, so that can help us to fight against obesity. And there are some effectiveness in this concept. There is lots of studies done on the meal replacement. So low calorie diet, how much their effect. So here we can see a beautiful systematic review and meta-analysis of the meal replacements for weight loss, and this forest plot clearly suggests the beneficial role of meal replacements. So the another systematic review and meta-analysis of all the randomized control trials done on meal replacement. So generally it has been seen that the MR based LED on weight loss was superior to the effect of who are on the receiving more than 60% of total daily energy intake from the meal replacement, and they have the greatest effect. So here we can see in the slides the group who are on more than 60% of their calorie intake from the meal replacement, they are getting the most benefit. So but there are some drawback of this type of meal replacement also, and for that the adherence is a very important issue. We should be very much, again, the first of few slides, as we give emphasis on the patient's preference. So we need to adjust our diet schedule as per the patient preference. But yes, of course, the meal replacement have a huge role in the obesity management. Now coming to the next part, which is exercise. So generally a total of 60 minutes of physical activity is recommended every day, and this should include at least 30 minutes of moderate intensity aerobic activity like brisk walking, jogging, gardening, etc. 15 minutes of work related activity like climbing stairs, walking during breaks, like that. And by thanks God to the due to this COVID-19, we are now not using lifts much more. We are now using climbing stairs. We use stairs much now. 15-minute muscle strengthening exercise is very important using light weights. Aerobic activity should be performed in bouts of at least 10 minutes in duration. Otherwise, it will not give the optimum activity. The total duration of physical activity could also be accumulated in a small of 10 to 15 minute periods of physical activity 2 to 3 times a day. The personalized exercise plan is very important. It is not like that the patient came to you and you prescribe you have to do 10,000 steps per day from tomorrow and 150 minutes per week of aerobic exercise from tomorrow. It should be gradually increased. Otherwise, the weight reduction program will be failed. We should have an effective exercise plan for weight management among patients with type 2 diabetes. Includes a combination of aerobic, resistance and flexibility exercises. This stretching exercises are extremely important, and this increase the cardiovascular health, muscle mass, and reduce the risk of injury also by exposing them to the different types of flexibility exercises. And sometimes it is recommended to see the patient's exercise capacity by 6-minute walk test. So when to start therapy, again, this is for the American populations, but for Asian Indian, the guideline is little different. The pharmacotherapy should be initiated for BMI above 27 without comorbidity, but if it is comorbidity is present, we should start pharmacotherapy more than 25 kg per meter square. There are some waist circumference specific cutoff also, and for surgery, if the BMI is above 32.5 with comorbidity, we should have a plan for surgery. And now coming to
Dr.
the different.
Shambo, you can make it brief.
Yeah, I have a 2 to 3 minutes, sir. Within 2 to 3 minutes, I will end. So efficacy of anti-obesity drugs, there are lots of drugs, but I will spend very less time with drugs because why I will tell you later. But these all the drugs are approved by FDA, but generally in India the lipase inhibitors, the orlistat is approved for obesity management, but there are lots of GI adverse side effects are there. We have different molecules like topiramate, bupropion, which is present in India for different other indication, which also gives some good amount of weight loss, but we need to be cautious of their different safety concerns. And yes, liraglutide 3 milligram is also the FDA approved treatment for obesity management, and there are some specific contraindications for liraglutide like pancreatitis and medullary thyroid cell carcinoma. So in India we have only orlistat, which is approved for obesity management. There are some phytopharmaceuticals which is available, but we need more data among that. Very recently, though it is more than 1 year happened, the lorcaserin was approved for management of obesity, but it is withdrawn due to the increased risk of weight loss. Why I spent less time with obesity anti-obesity drug? This is the cause, because the efficacy benchmarks, if we can go by the FDA guideline, then we will find they approve drugs to treat obesity if the difference in mean weight loss between the active product and the placebo treated group is at least 5%, and the difference is statistically significant. So you can see the 5% mark. And also another cutoff is there. If the proportion of the subjects who lose greater than or equal to 5% of the baseline weight in the active product group is at least 35%, is approximately double the proportion in the placebo treated group. So what is important to note that they will give approval to such a drug which failed to produce 5% weight loss in 65% of that active population group. So there are some important bariatric surgery which we need to know, and this is today's scope is beyond the discussion of that. But as we are talking about diabetic patients, it is important to consider the concomitant medication. There are some specific medications like pioglitazole, sulfonylurea, and insulin. They increase the body weight, so we need to consider it while prescribing these drugs. If we are thinking about obesity management, there are some obvious drugs which are weight neutral, like metformin, DPP4 inhibitor, alpha glucosidase inhibitors. There are some drugs which promote weight loss, like GLP-1 analog and SGLT2 inhibitors and pramlintide. And for that, there is a specific area where they are promoting to prescribe GLP-1 RA or SGLT2 inhibitors if there is a compelling need to minimize weight gain or promote weight loss. So we need to believe on this farm. That means whatever recommendations we should provide, which that should be few in number, individualized objective should be there, that should be realistic, and also it should be measurable. And this is very important ladder, that is the accountability ladder. So it is our duty to make our patient to this in this area, from this area. So maximum of our patient, while giving or prescribing anti-obesity drugs, anti-obesity therapy, they represent in this zone. And sometimes after 3 years, 4 years like that, they not understand the reality. So it is our duty to uphold those patients in this zone. At least they should acknowledge the reality. With that, I thank you all again. It is important to emphasize the epidemic of obesity in Indian population, because we are different from our Caucasian friends. So with that, I thank you and stop my screen sharing.
So thank you very much, Dr. Shambo Samajdar. So you have very eloquently elaborated on a very important area, and that is adherence to obesity management in diabetes, which is very important. And thank you very much. And now we go to the next session, and that is by none other than Dr. Debasis Basu, who is a senior diabetologist at Apollo Multi-Speciality Hospital, Kolkata. And as I know Dr. Debasis Basu since many years, he is also an excellent teacher. Okay, so we would always look forward to hear Dr. Basu. Dr. Basu will today talk on a topic title, and that is India Phenotypes of Diabetes and Adherence to Phenotype-Specific Management. Dr. Debasis Basu, please.
Thank you, Santanu, and thank you all the rest of the colleagues who are there, and of course Shambo for catching me. It is almost under the belt because I believe it was last Sunday. He called up and said that sorry, bolte hobe একটা phenotypes of diabetes in India. তার সাথে, this is a program on adherence, so adherence with phenotypes that is there in India. But unfortunately, I called Shambo up today, and in fact I was talking to Rohan also last night, that perhaps I did not have much data to talk about the Indian adherence and the phenotypes that connect. Nevertheless, I have tried my best to make some slides, and I will go to that, but I need to share, and I will not. What is happening? Just a second. Tata, কিছু একটা দেখতো? Can you see anything?
No, not yet.
Not yet, right. Now do you see anything?
I think it's coming.
What is happening here? There's so many. Tata!
Yeah.
Just a second, let me call my son.
If you select from the shared screen, if you select the only one screen instead of the entire window, there is a second tab. The first tab is the entire screen. Second tab is window. There you can select your presentation, and then only that part would be shared.
Sharing is easiest. You are saying I will do that window or not?
Yeah. From the share screen, there's an option of window.
Yeah, I've gone there. Sorry. Yeah. Now can you see?
Yeah, sir, it's visible now.
Right. It has come now. Okay.
Thank you. তুমি কে ভাই?
Sir, I'm Rohan.
কোন নাকি এটা? হ্যাঁ, আরে বেটা তুই তো ক্রমশ কেন এটা জাহির আব্বাসের মতো হয়ে যাচ্ছিস। যাই হোক, very well. So I'm sorry I kept you waiting, but this is the global estimate of diabetes population, and I'm very proud to say that I sincerely believe that we are the diabetes capital of the world, though the statistics talk about China because they have a better census mechanism. But I think all total, the diagnosed, undiagnosed put together, what we claim to be around 8 billion is much more than, especially after the COVID 20 months, we are much ahead of any other country, because China, it seems that China claims that they don't have COVID anymore. In fact, they behave like they have forgotten the word even. So this is where we stand. And we know that from 77-80, we are slowly heading towards a bigger number, and will obviously overtake everybody. So that's a dubious distinction. But why is it all happening? Is because we have a certain characteristics. And this is the particular characteristics. We are evolutionarily determined. And this is because of the poor beta cell function and the low lean muscle mass. So that actually leads to impaired insulin secretion. And of course, there's a response to lifestyle, which gives you ectopic fat deposition in places where you didn't want, like liver and muscles, and that gives you poor insulin sensitivity or impaired insulin action, and finally they contribute to diabetes susceptibility. So our Asian diabetes that diverges from the white Caucasians in a number of ways, especially the younger, almost they said 10, now they're claiming 13 years younger than the Caucasians. And of course, at a lower levels of the last slide that Shambo showed us was Yajnik and Yatkin, that YY paradox, same BMI, but very bad fat for Chittaranjan sir than Dr. John Yadin. Now, this is the Indian trait, and we have pre-diabetes quickly converting into diabetes, almost less than 3.5 years. And we have this typical phenotype, which we say that high levels of abdominal fat, which gives rise to more insulin resistance, even at a low level of BMI. So we understand now, not recent, but almost 10, 12 years now, that we also have profound beta cell dysfunction that comes in and sets in early, and that also progresses very rapidly. So therefore, type 2 diabetes is in a disease where we have no answer. Is a disease, I think, type 1 is purely a disease of the pancreas where the beta cells are not secreting. Then there are certain genetic entities. Then there is something like drug induced, like corticosteroid induced. We see so much in the COVID times. But what is type 2? According to me, it is a disease where we don't have yet any clue to what it is. So we have to find. We are in the search. So we know that insulin resistance is rising. And we have strong genetic factors for India, especially the Pro12 ALAP polymorphism of the PPAR gamma gene, which adds protection to diabetes and insulin resistance in Caucasians. They are not there for us, unfortunately. The role of environmental factors, the pollution, the quick epidemiological transition, the people who work in Kantapur and come to us as domestic help for daily maids, they take the leftover biryani that we keep overnight for them, and they rush to catch the last train in a hurry, and they're so stressful that they are actually transitioning now to a more than an urban scenario for the predilection of diabetes. And the physical activity is kind of almost not there. The dietary alterations that I saw Shambo elegantly speaking, I believe here I would like to say, I was thinking about this, I should not miss this opportunity. Now, as people like Santanu are not there in the city, directly, of course, in the cloud days and the networking days on air, nothing is, we don't miss anything. But Shambo is really is one of the finest teachers that I've come across. I wish I could have gone back into the days. Of course, I have to get a chance in the admission for a DM pharmacology. Even if I don't do Shambo, please help me, teach me. You are a prolific teacher. And of course, kudos to Shantanu, the predecessor who made what Shambo is. Now, Shambo talked about obesity, and that is it. And our country will perhaps, looks like it looms large, that it will become, we call USA, we call Saudi Arabia, other countries, but we are not less anymore. We are following them very, very fast. Now, this is a slide which I'll talk, and I will talk briefly. This is the Leif Group's department in Malmo, and they did this wonderful work. This is basically a study that they did for finding out what are the kind of subsets of population they have. So they had found out 5 clusters, and I will not touch upon them at all, but they are basically on these 6 variables they studied, and this is called the Scania report. In the Swedish population, newly diagnosed, almost 9,000 people in the Scania cohort. I will come to our work, and which is a phenomenal work, naturally, from who else but Dr. Mohan and his group. This is from the diabetes electronic medical records that he collected a data of more than 37,000 individuals, ranging from, as I remember, 10 to 97 years of age, and they had diagnosis of type 2 diabetes, and out of that huge population, more than 350,000, they finally segregated around 55,000 people who had the baseline data available for the variables of interest. We saw the variables in the Alquist group study. Here it was also the the age at diagnosis, the BMI, the waist circumference, the A1C, the serum TG, the serum HDL, and the C-peptide, because we know Mohan's group has been doing C-peptide fasting and stimulated for years together. And what they did was they selected around 20,000 population for reported duration of diabetes of more than 5 years. When they came to the that was less than 5 years, and they came first time for the clinic, and they segregated this population. And after merging the HOMA-B and the HOMA-IR and removing the other individuals with HOMA-B of more than 500 and HOMA-IR of less than 20, they removing these outliers and the remaining variables, which finally had in the study, the final sample size was 19,000, was less than 20,000. And out of which they also had people for positive GAD antibody test, which was around 66%. Now this is the data. Now what they call is SID. SID is a severe insulin deficient diabetes, which comprised of 26% of their population, and they had the lowest BMI and the lowest waist circumference, as well as the lowest C-peptide. So there was, whether it was fasting or stimulated, so there was no C-peptide secretion, no insulin secretion. So this is severe insulin deficient. Now, the cluster 2 was IROD. IROD is the insulin-resistant obese diabetes. And this comprised of another 26% of clustered patients, highest BMI and highest waist circumference, and of course, the highest C-peptide levels. So, severe insulin-deficient diabetes, insulin-resistant obese diabetes. Mind you, Mohan's clinic is actually flooded with more than 50% of the population who flock from either Bengal, like West Bengal, or from Bangladesh. So this is more of a reflective data of our indigenous population from where I'm speaking. There's cluster 3, which is combined insulin resistance and deficient diabetes, CIRDD, and that constituted to 12% of the study population. And they had the lowest age of the onset. The BMI and the waist circumference were intermediate between the SID and the IROD. There was this cluster 4, which was mild age-related diabetes, which was MARD. That represented the most frequent cluster in this population, around 36%, and was characterized by later age of onset and the highest HDL cholesterol. They fairly preserved C-peptide values from the stimulated ones we could make out, and they had more or less a better metabolic control of all the groups. And this group actually used the least of insulin out of his database of 19,000, I think 84. Now this is the area where I will say that the record which he actually gave us was a part of the INDIAB population, and MARD, of course, we understood was the most frequent cluster, 35%, followed by IROD, 30%. SID was 25%. I'm talking about the INDIAB study population. I'm now segregating this entire analysis to INDIAB, the ICMR INDIAB study, where this also came out. The CIRDD was around 7.6%. Now, SID had the lowest BMI. Naturally, they're like insulin. They did not have insulin deficient, and the lowest BMI, lowest WC, and the highest A1C. IROD, naturally, the insulin-resistant obese had the highest BMI and WC. So what I'm trying to repeat is the same, because I'm talking about the phenotypes. This is what has come out from the Indian data that we have so far. And in the SIROD class, in the SID CIRDD cluster, CIRDD cluster is the very important cluster, which is the most important, the combined insulin resistant and the insulin deficient cluster, where the BMI was, of course, in between SID and IROD. It had the highest triglyceride, it had the lowest HDL, it had high A1C and high diastolic blood pressure. Now, these are the tables where you can see, you can go there and find the highest diastolic blood pressure. MARD had the highest age at diagnosis and highest HDL levels, the lowest blood pressure, and the best metabolic control. Now, in all respects, the clusters that are derived from this ICMR INDIAB population behaved actually similar to that of the derived population from the entire Mohan diabetes electronic medical records they had. So then the study that they're doing, the All India, the INDAB study, the ICMR study, and Mohan's clinic own academy of DEMR, they match together. So this slide is tells us in a very simple slide, talks about that the goal, the time to reach the treatment goal of A1C less than 7, that was considered here out of the various clusters that he had. And they clearly showed, look at the graph, the dashed line, the march showed the shortest time to reach the goal, and third and said obviously the longest time. This is therefore the clusters that I just talked about, the subtypes of the clusters, which is there from Alquist group in the Leif group's presentation in Scandinavia, Malmo. And what we talked just about was Mohan's group, or the ICMR INDAB study group, where we are talking about the 4 groups. So this is Alquist group. They have found that these SAID group, these are the constraints of a Caucasian population not matching with the Indian population so far as MARD is concerned. But there they were very categorical. They could find out that in SIRD, which is severe insulin resistant diabetes, obviously the HOMA 2 and HOMA B, they were all high, and they really led to more CKD early. Obviously they had liver disease associated with it. In the MOD, they had better prognosis than the other clusters. So this was the Andes cohort. I'm not going to that population, but I will stick to this, that Dr. Mohan has done a fantastic work. It came out last year in August, and I think this also is reflective of our population. And if required, we can actually track our population on those lines. But from this, what we can actually decipher is that I will come to this adherence part. But before that, I would like to say that the precision medicine, the stratified medicine that we now talk about, can actually come to the limelight. So adherence is a very important issue, and we all know that majority of the strokes, the heart attacks that we have, we have because of the omission of one drug for a couple of days. Where you want to go to a party or a marriage ceremony and you tend to miss your drugs, and then you come back and land up in a stroke. So in fact, from my clinic, Kiran, who was kind of a very important part of our team, she did a dissertation and she found out almost 47% of the stroke population and 35% of the MI populations that the survey was taken from the 7 medical colleges had missed 5 days of the drug. So this is a very important data, unfortunately not yet published. I was actually coaxing Shambo to help us out with this kind of a publication. And what we now need to know is that there are agreed upon guidelines and recommendations by so many august bodies, and so many healthcare providers like us keep on telling that. But for the person's behavior, it is their choice that whether they can afford to stick on with the treatment, either maybe because of some problem of some price, or it's a family issues, and many other things which we'll come to. So can we have this quiz? And this is approximately what percentage of prescriptions are never picked up from the pharmacy. So so for example, I write a glorious prescription and I feel thrilled, but the person who goes out from my clinic just goes back straight home and he's so tired that he doesn't buy the medicine. And perhaps the local the population, the family believes that this is somebody from Apollo and we cannot actually maintain with him, so he takes him to a next doctor. So my prescription is not honored. So this is actually, I'll tell you, this is 20 to 30% of the prescriptions are not honored at all. Then what percentage of medications of chronic disease are not taken as prescribed? So either you're taking out of twice that is scheduled for you, or taking once, or you're not taking 2 days in a week. An estimated how much percent of the hospitalization older adults, the elderly population, almost 10% of the hospitals. But this is American data, and I'll tell you, this is much worse in our country. Up to $300 billion of avoidable healthcare costs are attributed to non-adherence in the US annually. A retrospective claims-based study, which is from the insurance, etc., they tell you that almost 1,705 patients with diabetes and dyslipidemia showed that adherence decreased all-cause mortalities by or medical costs by 15%. So this is, if you really can maintain this adherence, your cost, your mortality, everything improves. These are the good trials which says that, in a clinical trial setting and a real world setting, the gaps that exist is that there are huge gaps. And the A1C reduction gaps are also equally important because the gap is actually about adherence. And if you look at the problem more closely, you'll see that 75% of the efficacy gap is due to poor adherence, and these are the molecules or the medicines which provide more adherence in terms of percentage. So if you're giving a GLP-1 RA, and this is data across the world, this is V. Stevens' work, which says that even if when the government is sponsoring the medicine, yet you are not very happy to take the medicines, so you fail, and your mortality also suffers. This is the ultimate price of poor adherence and persistence. The greater likelihood of more complications, the more frequent hospitalizations, higher healthcare costs, and increased mortality rates. And this study that I was talking about, done by Stephen et al., this actually took a data from, it's almost 10 years or more, I think 20 years, I think, almost touching, 1997 data to 1999 data. And they said that people who were under the age of 65 were around 137,000. If you increase their level of adherence by 30%, their hospitalization risk came down by 20%. People who were above 65 years of age, if you could increase the level of adherence by 56%, the hospitalization reduced by 20%. So that gives us a clear indication that for some chronic conditions, whether it's diabetes, hypertension, cardiovascular disease, stroke, cancer, increased drug utilization therefore can provide a net economic return, as well as in terms of quality of life and hospital admissions that can be driven by this improved adherence with the guidelines that we all have all around. This is the 1 year mark after the initial prescription. Look, I will tell you, that's a very wonderful paper saying that first year and second year, the adherence less than 50% across the 3 oral drug classes at the end of 1 year, and that dropped to approximately 40% in the second follow-up year. So if you have only a very keen bench of your educators or a support system in your clinic, only this drops, the rate of drops from holding on to the medicines can decrease. And World Health Organization also noted that the average non-adherence rate is 50% more in the NCDs. So we now really need to take up this issue and talk about it. And I'm thankful to Shambo that he raised this very sensitive topic and a very very important topic where we should all put in our minds together and do something about it. Now, these are the most common reasons for non-adherence. Of course, first is forgetfulness, then the concerns for side effects. Suppose you take first insulin shot and then that night you go to hypo, and you are not explained clearly about the prognosis or the alert of hypo, and then you realize that no, it's not a good drug because the whole para was kind of woken up, and you were rushed to the hospital. You had to check your blood sugar for the next 3 days 1,000 times, and then you will never go back to that insulin molecule ever. And perhaps you'll wait for some time, go to some other doctor who will write some medicines, which also perhaps you will not be able to adhere. And mind you, somebody is giving you insulin for a good reason. I think the oral medicines at that point will not do much good to you. So one after the other, these kind of escalate, one cause after the other. The cost of all the medications, especially even insulin, after 100 years, it is still not accessible, affordable, or in the COVID times available. And of course, the low perceived need and the efficacy that you need to go to your doctors, you need to go into follow-up visits. Those adherences are also important. The characteristics of the disease, how morbid it is, how comorbid the other conditions are, whether the medication side effects of the other diseases are also bothering you. The tablet size is very important. The duration, whether it's, you're already burnt out, you're tired. The frequency of the expected intake. In the middle of the day, you have 2 medicines to take. The complexity regimen of the treatment, mix this, pull that, push into the other one. do all that, the severity of the disease, and you are tired and sick with life, and finally a lot of medication related complications. This is a very important point that as a in the pharmacology seminar we must all talk about, that 40% of the adults in the general community, they actually experience a problem with swallowing the pills. Out of these pills, out of these, about 14% delay taking the medication, and about 8% skip the dose completely. Pill size, the rough surface, the sticky surface, the sharp edges, and the bad taste and the smell are all believed to correlate with the increasing difficulty in swallowability and the oropharyngeal transfer. Whether it's oval, whether it's oblong, whether it's oval, or whether it's circular, they all contribute to the easy transfer and final absorption. And then you have so many methods of, whether it's an osmotically driven mechanism or whether it's a GITS technology, so many technologies also for the release of the drugs, and which might not be, good for everyone. Because you might not have such good epithelial structure in the gut. Maybe you don't have the transporters in you, and I'll come to that a little later. The problem with non-adherence is, therefore, we have poor clinical outcomes, and of course, the economic outcomes are even worse, especially in poor countries like us. So let us come to this precision medicine. And precision health is, we talk about that person, we talk about the biological markers that are available or that are being made now, all the environment around you, the epigenetic factors, and the behavioral health. So this is an emerging approach, and I thank Obama and the Obama Healthcare to take it to fruition, and this precision medicine is really doing wonders in the US and catching up to the dreams of Obama. The individual variability in genes, the environment, and the lifestyle of each person has to be notified, and that can actually finally dictate better adherence to therapy. So this is, one pill that you see, you give, and it gives so a boy, a small child who weighs 16 kgs, who's kind of say 3 years of age, you have a medicine for him. Then he grows into 16 years or 18 years, you have a medicine for him. This 18-year-old child now, so I don't call him a child now, but he's kind of grown up now, but he has a body weight of around 45. Now he really grows up like an Indian to an 80 kgs, and when he's about 34 or 35, you are giving him the same medicine. Now how it will work, or whether we are cutting the dose, or what are we doing? So that's, this is a pharmacology program. Or you give him half the dose at a certain age, whether it will respond to that lower dose. Or whether you're giving him 2 tablets because you think that you're getting good results quickly, you have 2 tablets, you get a higher response to that. Or whether you choose to some other alternative medications, which India is proud of, because now we are getting treatment of type 1 diabetes by Babajis and gurus with Jalpura and Tonas. Now, this is the patient population, the mixed heterogeneous patient population. The standard approach is you try that medicine that is given in the guideline, and that is maybe treatment A, so effective in 20% of the entire target population, 80% it is a waste. Or you have a tailored approach where treatment A, treatment B, treatment C, metformin, all work, because we've chosen that these are the metformin people. We give sulfonylurea, all work. We give metformin sulfonylurea to some, all work. Or we give metformin sulfonylurea and TZD to all, and these all work. And we are not confused, because we know that we are giving these medicines with not a trial and error, but with a whole lot of logistics behind it, or a big run of clinical trials, which has actually evolved and given us these answers. So we stratify this heterogeneous population from the disease subtypes. We saw those subtypes from Mohan's group, those 4 subtypes. We see from the demographics where they're coming from Bengal, their rice-eating population. We see their clinical features, and we also have to look into their biological markers. Then we stratify them in different categories. And then finally, we personalize. We consider one patient to be one individual. That's a patient-centric approach that we're talking about, but we're actually not practicing. And ideally, it will be according to the preference of that patient, with his shared decision-making about his family and the other colleagues of mine. The clinical features, the medication history he's already had, the environment around him, how he can actually tally and match with his environment outside his home, with his family and friends, or at work. And then the behaviors of his other habits like smoking, alcohol, etc. and finally the biomarkers. So this is how the precision medicine will finally give an answer. So the schematic approaches from traditional, you give one medicine which kind of a size fitting for all, and then you have a precision medicine, you actually have a heterogeneous group. Now you have stratified them. Now you give them according to their focus of their existing problems, or you repurpose them with the the newer guidelines and newer approvals coming in, or you invent a new kind of therapy for them gradually. Precision medicine in diabetes, I will come to this. Obviously, this is a big population. It's a very good paper which talks about the entire, this is JOA study, so it talks about how it is applicable to the whole world. And why do you need precision medicine? Is because of the heterogeneity, especially of type 2 diabetes, which we don't know what it is actually or how it comes. So the pharmacogenetic variation in these anti-diabetic drug action has to be talked about. We have, from the old ADOPT studies, we realized that the TZDs in the slim males, with a population of slim males, the A1C reduction with TZDs was less than the sulfonylurea. But in the obese males population, the TZD actually got the A1C reduction at a much lower level than the sulfonylurea. So this is from that Mastermind Consortium, and this consortium is actually from the Ivan Pearson group. And I'm extremely fond of this man. He is from Dundee, and who is looking at precision medicine, defying all kind of norms that Scotland used to boast about. Scotland thought that they did not have any genetic diabetes, but he's a quiet man, and he started working, and now he conceives an idea where he will do the registry of all the people around the Tayside, that's the part in Scotland, do their genetic workup and tell them that whether what they require. Now this is the work that also he is involved somewhere. They didn't think that they have the HNF 1 alpha Modi variant, but now he talks about from this United study, which is using pharmacokinetic genetics to improve treatment in early onset diabetes. So suppose we have a boy who comes to our lives at 29, he's lean, and we don't do anything. We consider that he has a 540, maybe he has a 300 blood sugar. So without doing much of C-peptide, etc., perhaps we will put him on an insulin. That's the kind of common trend, considering that this is. But now the times they are changing, we'll consider the might be type 2 diabetes. So we'll put him on perhaps a metformin or sulfonylurea. But if we can subject this person to, from the history of his family background, the pedigree, lineage, and we do the, the antibody tests, we do the what we call the UCPCR, which is the urinary creatine and the urinary C-peptide and the urinary creatine analysis, which goes more in favor of whether the patient has endogenous insulin secretion. Then we can actually find out that he's a classically HNF 1 alpha. I'm not talking about a genetic analysis, but this little bit of marker screening pathway, and we can put him on a sulfonylurea therapy. Or there are a lot of these patients or persons who are on insulin therapy. We can actually bring them back to sulfonylurea, and they can survive without insulin for another good 2 years, perhaps. This is how the switch is. You see, patients with HNF alpha diabetes had 5.2 greater response to glycoside than to metformin, and 3.9 fold greater response to glycoside than those with type 2 diabetes. So you understand this person who can be easily corrected with glycoside, we are perhaps wasting time with him either on metformin or on insulin, but only a sulfonylurea would have helped him. These are the studies from the Gaurab study, etc., that talks about the OCT1, which is actually where the gene products of every drug has a metabolism, has a transport, has a distribution, excretion finally. And if you have the genetic alteration somewhere at the drug receptors level, at the drug transporters level, or the drug metabolized enzyme level, there is this change, and which can be revealed through the pharmacogenetics. This is where the SCL, this is kind of the soluble solute carrier family 22 member 1 gene we're talking about here, and this is the OCT pathway of the metformin metabolism. And we often have in India, especially in Bengal, we are always acidic, dyspeptic. So we have so much of prazols, And maybe we are not getting adequate actions of metformin because they have this DDI, drug-drug interactions, or maybe the metabolism pathway is inhibited. Or maybe we are taking a person with CAD is taking ranolazine, or someone's taking any other metoprolol, or molecules which are actually inhibiting the right mechanism of action of these persons. So in India, we have found that people with the the type 2 diabetes with this kind of AA homozygotes for the SCL22A1 gene, they have increased possibility of responding to metformin treatment, and they are not dyspeptic more with the addition of metformin. So if you can choose them early, and if you have the gadgets to find this out, then we have we don't worry at all, and we are relaxed saying that this will work. Similarly for the PPAR gamma pathway, it's also a similar action that we see here. We know that the binding of the TZDs with the PPAR gamma and the retinoid X receptor complex that stimulates this conformational change, and that leads to the binding of the heterodimer complex to the PPAR gamma response elements in the target genes. Now that leads to the insulin sensitivity via glycolysis, lipogenesis, the adipogenesis, and the increased glucose uptake and utilization in the skeletal muscles of the liver. Now, a single nucleotide variation that happens in this PPAR gamma gene can affect this affinity for the TZD and therefore the therapeutic efficacy. And multiple studies have shown, this. You on the right, you see this missense polymorphism happening. This is in the Pro12 ALA gene, where it is on the if is of course the PPAR gamma gene, and that is associated with decreased risk of type 2 diabetes development. Now, and of course, increased insulin sensitivity. If you have something here, a change, an alteration, and of course, there's a pilot study done in South India again that showed the effect of the Pro12 ALA variants on the therapeutic success of PIO, and they reported a significant association with this glycemic control. So single nucleotide polymorphism, the SNP, that disrupts the motive, the natural motive or a disease-related motive, and the binding. So we can actually address all these problems by doing the right thing, by cooperating factors like these motives can be altered. Variable PPAR binding, gamma binding control gene expressions can be looked at, and therefore for better anti-diabetic drug response. And this can, of course, modulate a big amount of human metabolic disease risk. The next slide is about the sulfonylurea. And I know, of course, in this kind of a conference, where we all know about the KATP channel and the binding of the sulfonylurea and how it all happens. But, when there's a variant, and that leads to improper closing of the KATP channels with the binding of the sulfonylurea, that leads to subsequent poor membrane depolarization. And of course, there's less influx of the, that voltage-gated influx of calcium, and the voltage-gated calcium pathway doesn't take over, and that, of course, will not squeeze out the insulin from the proinsulin, that cascade in the Golgi apparatus, and we'll have delayed insulin secretion. So, low levels of insulin molecules will there be available to bind to the IRS1, and therefore the impaired signaling cascade will follow, and we will call this man an uncontrolled person with diabetes, because we have not targeted that area of his choice that he deserved. So this is the classification of how many genes are involved in these medicines that we commonly write, and this is how we should actually present scenario, as we know that has to be A1C has to be less than 7 or 6.5 as you choose, according to the condition of the person, the life expectancy, etc., the complications. You give them lifestyle, you give metformin, you add one, they add the second one, up titrate, whatever. If you have this kind of a future perspective where we know about what kind of adverse effects this drugs can have for the patient, who are the good responders, who are the bad responders, then we can actually address these issues better enough. So these are the areas which we can talk about. The principles of the precision medicine in diabetes is we have to match the right drug to the right patient, or vice versa, and it has to be based on all the related factors like comorbidities, drug tolerance, cautions, Early combination therapy, of course, now from the Verify trial, we know. And of course, Stephen Del Petro was always talking to us that don't go for this sequential waiting therapy. Bombard the patient with all he requires at the first go, because the glycemic legacy is what matters. So right within 1 month, get him under control, and therefore no complications. He will live a normal life, which a normal person who thinks is normal will perhaps never can lead, because he will never check himself up according to the guidelines that are recommended, and he might have unwarranted, unforeseen, elements or ailments in him, that he'll not be as good as this kind of a person, whom we are actually taking care of these egregious 11 with all kind of CV, cardiovascular assessment, not only cardiovascular, microvascular, all these assessments will keep on doing, and will be taking care of this person. And prioritization will be based on the glycemic benefit plus the other pleiotropic elements that we talk about for every molecule. Now we talk about SGLT2 inhibitors, the GLP-1 RAs at length, because we say that these are the medications which are actually addressing so many. These are the disease-modifying drugs today, and disease is not diabetes. Diabetes is just a kind of a it's a wonder name for so many diseases to stay together. So we need to have a beta cell construct, and I'm sure people in this meeting who all know about egregious 11, and this is if you want to kind of brush it up, you can go to Stanley Schwartz, the egregious 11, the beta cell construct, and he has a lot of things to talk about. And I think it is a very, very important. Out of ominous opted, these are another 3 areas where we are now talking about. We are talking about actually, immune dysregulation, inflammation, the other brain properties, etc. etc. Now, I'm coming to yes, Dada. Sure, Santanu, I'm coming to the last bit of it. Yeah. So, no need for early insulin. We can look into these egregious 11 principles, and we need to understand that precision medicine, of course, it would be the choice to come forward. And this is human-specific roadmap for future diabetes research, human beta cells and human populations, as we take to the functional integrity of all the immunobiochemistry, the markers, the molecular genetics, the GWAS, the Gen-wide association studies, the modeling, and the trials that people like Peterson and Pearson are recommending. We will definitely have new targeted treatments. We can have these data-driven clusters, and we can actually change the world into a much happier place, whether there is COVID or not. Thank you.
So, thank you very much, Dr. Basu. It was a very extensive and very thought-provoking. Yes, we cannot ignore the genetic makeup, and because we all know it is the gene that actually is responsible for our phenotype. So, no lecture on phenotype, and decision on treatment in different phenotypes can be complete without consideration of the genetic basis. And you have very wonderfully covered most of these studies also in this area. I was just wondering whether in India, the 4 clusters that you have mentioned from the Mohan's study and also the ICMR study, whether they have gone further regarding the treatment response, and also probably this is one aspect. And then I was also thinking about differences in patient behavior in India, whether the Indian patients for that matter behave similarly or they behave differently so far as their adherence to treatment is concerned, whether there has been some study. Most of the studies what we find, it is actually describing what is the adherence problem in India and the magnitude of the problem. And also some of the studies, they have also done some interventions to improve adherence. But so far as the treatment adherence in hypertension is concerned, how the Indians behave almost similarly as their counterparts in the rest of the world, or they have a different kind of behavior given the overall milieu where they are receiving their treatment, they are being diagnosed, they're expected to actually uh, stick to the treatment that they are advised, etc. I think there has been some research gap in this area also, and I believe there is a huge scope for qualitative research in this area, that if your patient is not really complying with or adhering to the treatment that you have advised, what could be the possible reason, and even if when you are trying to intervene, to what extent you are succeeding. Even the best of the intervention studies for improving adherence has also shown that they are not really producing the kind of result that they are expected to. So there is a huge area, research gap, and there is a huge scope for further work in this area. But then it was a wonderful eye-opener, and it was a great lecture. Thank you very much, as usual, Dr. Debasis, Basu. It was wonderful. Thank you.
Thank
So
you.
now we go to the next part, and yet another very important area, which is going to be dealt with by Dr. Gaurab Bhadury, who is a consultant in diabetes and endocrinology, and he is attached to affiliated to Medica Super Specialty Hospital and Apollo Sugar, Kolkata. Dr. Gaurab Bhadury will be speaking on timely initiation of insulin and titration of dose in management of type 2 diabetes, adherence to guidelines. I would only request Dr. Bhadury to be a little brief, because we have already crossed the limits in last two sessions, so we don't have much time left. But then I think if you could complete by maybe 20 minutes, Dr. Bhadury, please.
Thank you, sir, for the very kind introduction. And I thank the organizers, and especially Dr. Shambo Samajdar, who is a very good friend of mine and a great academician. I must say, he's brilliant at his work. And I was listening to Dr. Debasis Basu's lecture. It was really, an eye-opener, and there is no need of introducing him. Everybody knows about his work in diabetes. So I will try to limit my speech to about 15 to 20 minutes, because I also have a personal commitment after that. So I will definitely try to keep in within the time. So let me share the screen. Is the slide visible, sir? Santanu, sir, is the slide visible?
Yes, it is visible.
Okay.
We can see this. Yeah. Go ahead, please.
Okay. Fine. So, thanks to everybody for the very patient, waiting, because my start time was around 9. So insulin initiation and intensification is what I'm going to talk about today. And it is very important to understand that when we talk about insulin initiation and intensification, there are a lot of data, but I will not be taking you through much data today, because what I believe is the biggest barrier to understanding of insulin initiation and intensification is the barriers that exist both on the side of the doctors and the patients. So I will try to demystify some of those and give you some of the practical tips that you might carry forward it into your clinics and try to implement them to get a better response of insulin acceptance by the patient. So the problem with medication or oral tablets, as all the other speakers were talking about, were adherence. But here the problem is that you cannot get a confirmation from the patient to accept insulin, and that is so much prevalent in a country like India that it is so important to get into this understanding that why patient is refusing, understanding the psychology behind it, and why sometimes doctors are also hesitant in using insulin in the place where it need to be. Now, we all know about the burden of diabetes, and it is not an unknown phenomena that we are growing at a rapidly massive speed, especially in the Southeast Asia region. And in the world, it is expected to grow by around 640 million diabetes by the year 2040. In the Southeast Asian region, we are expected to have around 140 million. So the numbers are going to be catastrophically great. And despite multiple therapies, majority of type 2 diabetes patients have uncontrolled HbA1c level. So if we look at this Discover Study program, we see that the Southeast Asia cohort, they have in India and Indonesia data, so less than 7% control is in the green bar is extremely less. So most of the patients are in the red zone, which is more than 9% HbA1c. And even if you see in the bracket in between 7 to 7.9%, or 8 to 8.9%. So that also contributes a great chunk of our patients. So globally, 26.7% of the patient has an HbA1c, which is more than 9%. Highest proportion in the Southeast Asia region, India and Indonesia, around 35.6%. And only around 17.4%, which is less than 20%. So attained a target HbA1c of less than 7%. And 13.4% in the Southeast Asian population. So this is, an eye-opener for all of us. So where we are heading towards a good HbA1c control. And if we all, I have not put in all those data over here, but if you also look at the use of insulin, especially in India, so the numbers are not very good, rather they are really disappointing. And patients are maintaining a very high HbA1c. The use of insulin is also dramatically low. This is something we need to improve upon as we go into the next decade. So at diagnosis in the Wikipedia has revealed that a majority up to 50% of the beta cell function, 50 to 80% of the beta cell function is already lost by the time we are getting a diagnosis of diabetes. And majority of our patients already have some kind of complications. Now, if you look at the Montreal data, we all know about this. So contribution of postprandial glucose is greater as the HbA1c level improves. So this is the Western data. But if you look at them first, and then I will take you through the Indian data. So what they're saying is that when the HbA1c is on the very highest side, the postprandial contribution is comparatively less in the Western population. But as the HbA1c start coming down to the target range of near about 7 and 7.5%, the contribution of postprandial glucose in the HbA1c is much greater now in comparison to the fasting glucose. But what happens in the Indian population is that even at very high HbA1c, the postprandial glucose contribution is much more significant than our Western counterparts. So this is something which is different in the Indian population, and that might be because the majority of the Indians are consuming a high carbohydrate meal. Now, recognizing inadequacy of the oral therapy is also very important because, as I told you, at diagnosis, there is more than 50% loss of beta cell and yearly 4 to 7% reduction in beta cell function is happening. So ideally, 2 to 3 OADs maximally used might be one of those indicators where we might be thinking that probably this patient would be needing, insulin addition to the current therapy. But these things, again, as Dr. Basu was talking about, this is precision medicine. So we need to be talking about, things at a very individualized level. So increase in the hyperglycemic symptoms, weight loss, these are also some of the things which might prompt us to use of insulin. HbA1c constantly above 7%, duration of diabetes, longer duration, at least more than 5 years. Okay, some of the patients might be doing extremely well on OADs for 15 or even 18, 20 years. But we need to be careful when once the diabetes is crossing the mark of 5 years, because some of our patients would be needing some extra intervention to keep on with a good glycemic control. And significant insulinopenia, if we find, then obviously is a area where we need to be using insulin. So these are kind of rough markers that can give us that which patient might be benefiting from insulin, and we need to take our call based on that. We all know about the type of insulin preparation. We have human insulins, the regular human, the NPH, the premix formulation in either 30/70 or 50/50. Then we have the insulin analogs, the P-cell analogs, the glargine. Now we have U100 and U300. We have detemir, we have degludec. And then we have rapid analogs like Lispro, Aspart, and the glulysin. And we have pre-mixed formulation. And why this is happening? Okay, so pre-mixed formulation and the current or the new generation of co-formulations also we have with us. Now, the pharmacokinetics of insulin preparations, we know the rapid ones or the short and the regular ones are, acting very rapidly, and they are usually used for the postprandial control because they mimic the postprandial insulin release. And then we have the NPH or the intermediate acting, and then we have in the long we have Detimir, and then the ultra long we have Degludeg and the Glargine 300. So these are the kind of profiles we are going to get after hours of injection of insulin versus the insulin level. So we all know about them. Now, the most important part is we all know about insulin. We even sometimes many doctors tell us we also know what is the dose recommendation to be used, but there is a hesitancy of using insulin initiation. First and foremost, I think the barriers from I should divide it into two parts. So first, let me talk about the doctor's side hesitancy and the barriers that they face. So as I talk with more and more doctors, so what I understand from them, the first fear is that ultimately the patient will not be taking the insulin, and at the end of the day, that patient is not going to come back to me if I prescribe them an insulin. And this is, no matter what we say, this is a reality. This is a reality. Every time we prescribe insulin, we might anticipate that a significant portion of those patients are not going to come back to you. And that is a reality. And we need to face this reality and then take the action accordingly. What can we do? I will talk about later. Second is the risk of hypoglycemia. So this is also something which we doctors need to overcome by actually gaining knowledge about how to use them and how to minimize the risk of hypoglycemia. And not only that, you also teach the patient, about the hypoglycemic alert that the patient needs to know. What should the patient do if there is a hypoglycemia, and how to detect it, and what the actions that needs to be taken on an immediate basis. So these two, I think, is the most important barrier from the clinician's perspective or the doctor's perspective. But there are a lot of other barriers from the patient's perspective. So patients are usually, what I personally in my clinic, what I feel is that patients are extremely afraid to take insulin, again because of two major factors. One is usually hypoglycemia. I agree with that. That is a reality that can happen with insulin. But most of the patients are worried more regarding the myths that are associated with insulin. That insulin, if it is used, it is like something which is not safe, and it might cause different kind of problems, maybe renal issues or issues to the heart. And because why this has happened is because they have seen patients using insulin who also has a chronic kidney disease, or who also has a cardiac issue, or maybe returning from the hospital. So because of this misconceptions about insulin, they are actually thinking that insulin is probably not a very safe agent. So we need to break those barriers through a proper, teaching the patient that how safe insulin is in using. So what I usually do in my clinic is that whenever I start treating a new diagnosis of type 2 diabetes patient, I tell them about the progressive nature of type 2 diabetes and tell them that I will start you now with an oral medication, but later on the dose will need adjustments. And over a period of time, I don't know how much, but depending upon how well you treat yourself or do exercise and take your lifestyle modulations in a proper manner, and on your genetics also. So these three will together, determine that, and also the consistency with which you keep your medication adherence and everything going on. All these things together will determine at what time you will require insulin. But somewhere during your lifetime, there is a great probability that you will be requiring insulin. And when you require it, do not shy away from it. Okay, this is just the natural course of diabetic history. So if you tell this to your patient when the patient is coming to you for the very first time, even after 15 years, he might not be coming to you, might be going to another doctor. By the time, he might not be staying in Kolkata, he might be staying in Delhi. But that doctor who will be treating at that point of time, prescribing him insulin, he will have a much lesser hindrance, because this person is already educated about the progressive nature, and this has been told to him from a very early background. So this is something which I do for all the newly diagnosed type 2 diabetic patient that I see in my clinic. So this is something you can adapt also. So overall, we will be helping each other. And next, what I say is I never tell the patient that I'm giving insulin because it's your failure. Always communicate with the patient in a positive note. Even if the patient is not following your adherence, try to look into the cause. Do not scold, because that hardly works in the long term. Okay, the patient will not be following your instructions by scolding or making them feel bad. It's not going to happen. No matter how much we believe in it, we have to make them understand. Try to understand what is causing the problem, why is it not taking it, and try to delve deep into it. And if possible, if you can make them understand, or the family members understand, you can also take psychological counseling sessions for the patient. Okay, at the appropriate place, you can ask them to take that. But these are also very important things to overcome before you are facing a difficulty with insulin. Another very common question that we get is, once I start insulin, I will never be able to stop. So there is a perceived loss of control over one's life. And provide a sense of control regarding insulin. Present it as a temporary experiment. Try it for a month and see how you feel. Once you feel good, if you are feeling good with it, if there is no problem with it, then we can discuss on the next date. Okay, so don't give a very long timeline from the very beginning. But don't tell the patient also, no, we will be using it for a very short time. So you play somewhere in between the gray area, because if you tell that you will be requiring it for the lifelong, so sometime there is a patient goes into a state of anxiety, and there is a loss of control over one's life. So prescribe once daily insulin if that is possible. So we'll discuss a little bit about that also, because that minimizes the inconvenience. Taking insulin is too complicated, so there is a lack of self-confidence that I am an old person, I will not be able to take insulin of my own. So just show them, ask them to buy insulin, and just show them that how simple insulin is to use. Maybe you give them 1 unit, 2 units, just demonstrate it in the office. If you don't have time, ask your diabetic educator or your dietitian to just demonstrate that in the office, and you will have splendid results. I'm telling you, patients will just feel that it is painless, it is so easy to do, and once they have done it in the office by themselves, they will go home with a lot of confidence. I did this to myself is another very negative thing you will be hearing from patients, equating insulin with personal failure. So never do that to your patient. If the patient is doing this to himself, make him understand. At least what we doctors can do, don't do this to your patient. Don't make them feel that insulin is something of a punishment. If you are not following your diet, exercise, I will have to use insulin. So don't put it like that. Okay, so stress that the need for insulin is the function of the underlying disease, not an indication of failure at proper diabetes self-care. My uncle went on insulin right before the leg he lost. I was talking about the kidney disease issue. So perceived disease severity, frame the insulin message properly, emphasize that type 2 diabetes is a progressive disease and that requiring insulin is a natural part of the progression. And I always tell my patients, see, pregnant woman, have you seen someone? So relate with something that they might have seen in the family. Let's say pregnant woman, they're given insulin. Okay, so if they have type 2 diabetes, they go on to have pregnancy, they will be given insulin. It is so safe that it is even given to a pregnant woman. Okay, and then if you have kidney disease, then it will be given because it is very safe. If you have very severe liver disease, it will be given. If you are admitted in a hospital or acutely sick, it will be given to you because it is the most safe option to give. So like this, you just counsel your patient, make them understand, and one of the other thing they will relate with either themselves or someone in the family, and then they will probably understand the message that you are trying to give to them. I can give myself injections, they hurt too much. So again, injection related anxiety is there. So disprove injection related phobias, demonstrate them, show patient that insulin injection is less painful than blood glucose monitoring with a glucose meter, and tell them two things very, very important I do in my practice is tell them to change the injections either after a single or a double prick. So no more using than a 2 pricks with the same needle, and don't use cold insulin. So these two things, if you take out and teach them, it will be extremely effective. Now, initiating with a basal insulin, addition of once daily basal insulin to oral therapy in the treatment of type 2 diabetes is the most popular regime in clinical practice worldwide. Now, most of the guidelines, including the ADA, ESD, IDF, NICE, and Chinese Diabetes Society, recommend initiation of insulin therapy with a basal insulin. And why they do is the usual dictum is to fix the fasting first. As I told you, very high HbA1c in the Western population, the contribution of fasting is much, much higher than the postprandial contribution. So for them, it is actually a very good choice to start with a basal insulin. And actually, that is the reason why all the Western guidelines will suggest using a basal insulin. Even it is true for some category of our patients also, where we have a choice of actually using a basal insulin upfront rather than using any other strategy for that patient, and maybe using also oral therapies along with the basal insulin. So this is the situation with the basal insulin. So these are the common basal insulins we have. NPH we have, Glargine now U100 and U300 also we have. Then Detimir we have, and the Degludec we have. So if you look at the efficacy, all are similar. Risk of hypoglycemia a little bit lesser with the newer generations basal insulin. Cost obviously is sometimes prohibitive regarding Degludec and the U300 Glargine, but they also have reduced the costing a little bit in the last year. And if you look at the convenience, so obviously user friendly being a single dosing, so Glargine and Degludec here is actually gaining a little bit of better compliance with the patient because of easier convenience. Now, why basal insulin fix the fasting first? Because lowering the fasting first will lower the postprandial values throughout the day, and thus will also reduce the PPG and may be sufficient. So elevated fasting hyperglycemia and the hepatic glucose output, if you reduce it by the basal insulin, the base comes down, so the postprandial surges are also going on comparatively on a lower range. But you can also use oral medication, so basal and oral therapies together to bring down you can use oral therapies to bring down the postprandial blood glucose. So targeting the basal insulin for the fasting and maybe oral medications for the PP can be a very good strategy. Now, initiating with premix insulin, so Indian guidelines suggest the initiation of insulin therapy with the premix insulin, as well as you can use basal insulin also for some of our patients, but Indian guidelines are more free with use of premix insulin. And if you look at the IDF, they also suggest using either a basal or a premix insulin if the OHs have failed to achieve a HbA1c target of less than 7%. And postprandial contribution to hyperglycemia is more pronounced in the ethnic Asian communities. Premixed insulin that improves the postprandial should be the preferred method of insulin initiation in this population when both FPG and postprandial are high. And this can be one of the strategies. I'm not saying that this is the best strategy, but this can be one of the strategies when FPG and PPG both are high. And the difference in between the fasting and the plasma is quite high. So only bringing down the fasting will probably not compensate for the postprandial lowering. Now, if you look at the dosing and titration of once daily basal insulin, very easy. So you can start with a 10-unit dose at a fixed time, either at bedtime or in the morning. So in the elderly population, I believe it should be given in the morning rather than at bedtime. The recommended target of fasting is to keep the fasting in between 80 to 130. Recommended to titrate the dose once in a week or maybe once in 2 weeks. So it is recommended, don't go very fast, take it slow. It is recommended to modify dose based on the lowest mean of the 3 most recent fasting values, or you can do a weekly twice measurement for those patients who do not want to prick more. So you can do a twice a week measurement, and you can do it. It is recommended to reduce the dose by 10 to 20% for patients reporting hypoglycemia. Again, very, very important. And simple algorithm is less than 80, decrease by 2 units if you started with a 10-unit dose and you are escalating. So just follow this regime: 80 to 130, no change; 131 to 60 plus 2 unit, then 161 to 180 plus 4 unit, and more than 180 plus 6 units. Now, if you look at the premix titration, what we do is we measure the pre-breakfast and the pre-dinner values. At least these are the two at least values we need to check. And based on that, if we measure the pre-breakfast value, then based on that we will change the pre-dinner, and the pre-dinner values, based on the pre-dinner values, will change the pre-breakfast dosing. Again, the regimen is very simple. If you see less than 80 minus 2, 80 to 130, there is no change; 131 to 160 plus 2 units, 161 to 180 plus 4 units, and more than 180 plus 6 units. So if you are using a premix in a OD titration, so this is a JAPI 2017 recommendation. I'm not saying this is the final word, but this is a very easy for primary physicians to at least gain confidence regarding premix titration. So you can start with a 10 unit once daily, either at pre-breakfast or pre-dinner, and gradually you can titrate the dose, and based on that you can either get already a good control, or you might decide to go on a premix BD, then escalating it further. And if you are using premix BD from the very start, if you are very conservative, you can start as low as 6 units. It's important to start. It is not the type of insulin you're using, but it is very important to start the insulin. If you have started the insulin, you have 150% of the race, because now the patient is amenable to, you have done your counseling part, the patient is now amenable to use of insulin, and this will make the journey after this very smooth. And also tell the patient on the very first day of starting insulin that the start of insulin is not the end to the problem. So we need to titrate the insulin, tell it from the very start, because some of the patients think that once the insulin has been started, now this whatever dose has been given, there is no need to visit the doctor after another week or 2 weeks. So this is again a very misconception that is running in the patient's mind. So tell them that we need to see you, we need to titrate. Until and unless we titrate, this is not going to solve the problem. So when to stop increasing basal insulin is also very important. So HbA1c goal, if you are not meeting, even when the dose is reaching about 0.5 unit per kg per day of total daily basal insulin, now they are saying you can go up even further. So, but just try to understand that if you're not able to meet the target with a very high basal insulin dosing, then some problem is there in the postprandial control. Elevated HbA1c despite normal fasting with basal insulin, and fasting FPG with basal insulin within target range, but fasting control, but PP is still persistently above the goal. This is all obviously an indication. And further increase in basal insulin results in hypoglycemia, and especially the nocturnal or the morning hypoglycemia, fasting hypoglycemia. So these are the areas where we need to decide that probably there is a need for a prandial insulin requirement. So basal plus and the basal bolus titration is quite similar, because if you look at the basal plus, similar is done for the basal bolus also, because the prandial dosing needs a specific kind of adjustment. So fasting is very similar as I have shown you with basal. So the postprandial is that for PP sugar measurement you need to do, and based on that in 140 to 180 you need not change, 180 to 200 plus 2 units, 200 to 220 plus 4 units, and more than 220 plus 6 units. So this is a very simple titration algorithm for the prandial insulin that you're using, whether you are using in a basal plus, which is basal plus 1 shot, and or we are using in a basal bolus, where we are using basal plus 3 shots or at least 2 shots. So you can see that titration again very, very similar. If you are shifting to a complete basal bolus therapy, so from oral medications, so you can take the total insulin dose as 0.3 to 0.5, mean of 0.4 unit per kg body weight, and you can divide it either as a 40-60 ratio or a 50-50 ratio also, and you give 50% is the basal and the 50% you give in the prandial, and then you can divide it by 3 and just start before each meal to start with, and then you can titrate based on this particular prandial insulin chart, prandial and as well as basal insulin chart. And I try to complete my lecture as fast as possible in a very limited period of time. And I hope I have made given you a little bit of understanding regarding this particular area. And I am handing over my session to the chairperson, sir. And thank you again for your kind listening.
Thank you very much, Dr. Bhadury. You have very nicely, within a short time, you have covered the role of insulin, particularly adding basal insulin to the oral medications in type 2 diabetes. That has definitely come in the guidelines and recommendations, but you are very right that it will take time to popularize it. And there are serious hindrances, and from the physician perspective and as well from the patient's perspective. But then, yes, and on the other hand, so far as adherence is concerned, it is also said that the simpler the better. So when you are trying to mix the insulin and the orals, so that may also probably be one of the uh, factor that may otherwise influence the or adversely tend to influence the adherence. But then this challenge has to be also taken, because this is also based on evidence, and here is a clear practice gap, that what we find in evidence, we find it very difficult to implement for that matter. So, but then hopefully that with more and more development of insight, and we would be able to really implement this. And it also underscores the importance of diabetes counselor, or trying to employ a team approach in diabetes management, rather than solely dependent on the physician who is prescribing, at least in Indian setting. So it's more a team approach that appears to be, which will have more potential, greater potential to succeed. So with this, I think you have wonderfully also covered this area. I now hand over to Dr. Shambo for the next part of the proceedings. Dr. Shambo, please.
Thank you, Dr. Gaurab Bhadury. It is really wonderful to hear you. So we are now moving to our next part, and for that, I request Professor Santanu Kumar Tripathi sir to take us through the journey on poor treatment adherence among diabetics in Indian context. So over to you, sir. Sir, your screen was visible, sir, initially. You have to select, sir, you have to select the PPT, sir. No. Now, sir,
Okay.
it is, you have to stop sharing now.
Stop sharing.
Yeah. Now you have to share the screen.
Yeah, I'm trying.
If you
Can you
select
please-
in the share option, if you select the window instead of
I
entire
select the
screen,
window.
then you no, there is an option of window next to entire screen. In blue, you see it's entire screen. Next to that, it's window is written.
Yeah, I'm clicking on the window.
Huh. So first you need to switch on your PPT. I think you click your PPT off. So that's why it's not visible.
Is it visible now?
Uh, no, not yet. If the PPT is open, then click on share.
Yes.
and then click on window. Then you will see the option of your PPT window.
Can I send the PPT to you?
Yes, of course.
It's sent.
To T Rohan.
To Tiro.
Sir, there is some echo is coming from your side, sir. Sir, any device that is open from your place, sir, or any another device?
Yes, probably. I'll just try.
Till Rohan shared, yeah, already Rohan has shared.
So now it is.
Yes, sir.
I can see this. So make it full
Yes,
screen.
sir.
Yes, it's full screen.
Okay.
No, it is not full screen. You have to make. You have to click on that full
Okay,
screen button.
just a moment. Just a moment.
No.
Is it full screen now?
Let's come.
Yes.
Yes. Yes.
Okay. Okay.
So it's visible now. It is visible, no?
Yes, it's visible.
Yes, sir.
So we have come towards the end of this today's session, today's program, and my job is to talk on this treatment adherence among diabetics in India, strategies to improve. So my job has been made simpler because all the three uh, learned speakers before me, they have covered most of the things in reference to this topic. I just touch upon some of the very basic and simple principles in reference to adherence. Now, when we talk of adherence in diabetes care, we need to remember that good glycemic control is always extremely essential for lowering the risk of complications of diabetes. The possibility of hospitalization could be minimized by good glycemic control, and definitely it will prevent all-cause mortality or lower all-cause mortality in the diabetics. And good adherence is the key to good glycemic control. When we say good adherence, we actually not just limit to medication adherence. When we say good adherence in diabetes care, we actually refer to good adherence to D, E, and M, what Dr. Shambo has very nicely pointed out in his lecture also, that it is diet, exercise, and medications. Truly speaking, when for the first time diabetes is diagnosed, at least mild diabetes, one would go for only diet and exercise, and with the expectation that it will take care, and the need for medication might be might be delayed. If it is say really pre-diabetic or it is a very mild diabetes, many a times, particularly in the obese, etc., the diet and exercise may also do the magic and can delay the necessity of institution of medication therapy. But then, uh, even after the medication has been instituted, importance of diet and exercise always remains. So, good adherence means good adherence to all the three treatment modalities, which has to go hand in hand: diet, exercise, and medications. It remains a fact that all over the world, and India is no exception, that a good proportion of the diagnosed diabetic subjects, they do not take their medications as prescribed, they do not observe the dietary discipline, and they do not undertake exercise as advised. So they are actually not adherent to the advices or the recommendations in reference to the treatment that is given by the healthcare professionals. So if adherence is suboptimal, it is no wonder that there will be poor treatment outcomes. Adherence to oral hypoglycemic agents in type 2 diabetes, there is a huge variation. There are many studies that have come up with different statistics, and overall it is found that it ranges from 36 to 93% adherence rate in uh, in oral hypoglycemic agents in type 2 diabetes. When you talk of insulin, it is to the tune of 63%. The reasons for poor adherence are many. Some of the most notable ones are perception about the treatment, as has been also mentioned by all our preceding speakers. The complexity to treatment, more complex the treatment is, the less adherent it is likely to be, and also the safety and tolerability, the adverse effects. If there is adverse effect of insulin, if there is adverse experience, then the patient can relate that it could be, or patient guess or suspect that it could be because of the treatment, okay, or for diabetes. Then they may stop taking the treatment. Now it goes without saying that education, patient education, and proper close monitoring, they remain the key to good adherence. Now can you go to the next slide, please? Now, if we for a second, if we think of medication adherence in general, not just in diabetes, these are some of the statistics that we find from the literature, that for every 100 prescription, and Dr. Debasis Basu was also mentioning that not necessarily when you prescribe, you should not take it for granted that as I have given a very good prescription, and so we are going to expect a good outcome, treatment outcome. It hardly happens, because for every 100 prescriptions written, only 50% to 70% of them are filled at the pharmacy. 48 to 66% of them are picked up from the pharmacy. That means the medicines are refilled, the prescription is refilled, and medicines are collected. Not necessarily all medicines that are collected from the pharmacy are to be consumed by the patients. So only 25 to 30% are taken properly, and 15 to 20% of the medicines, they are refilled as prescribed. That means it may have been taken, okay, for a given period of time, but then particularly for diseases, chronic diseases, which will require long-term therapy, prolonged medications. So in such situations, there has been a inherent kind of inertia or inherent kind of tendency by many patients not to get the prescription refilled. So that happens with 15 to 20% of patients. So this is the overall problem with medication adherence only. Okay, and diabetes is not an exception. This can happen, and this does happen in diabetes too. Next, please. So when you talk of adherence, there are in fact a number of terms are used to refer to what we mean by adherence. So there is a term called compliance. There is a term called concordance, which try to tend to mean the more or less similar thing, but basically there are subtle differences among them. While compliance is a paternalistic view that the person is a passive party, the patient is a passive person, individual, who has his or her prescribed treatment enforced. So I come to the doctor writes a prescription, and the doctor expects that whatever has been written is to be taken, is to be complied with by the patient, by me. So it's a paternalistic approach. When you talk of adherence, the paternalistic approach still remains, but then there is a little more adding to that. That is, I am adequately informed by the doctor or the healthcare system, but still my role remains passive, even in adherence. So I am expected to actually stick to or adhere to taking the recommended treatment. Although the difference between compliance and adherence is, in compliance it is entirely passive, while in adherence there is some amount of information that is shared, and it is expected that it is also discussed with the patient, and then the medicine is prescribed. On the other hand, concordance is on other extreme, where it is the process of enlightened communication between the person, that is the patient, and the health professional, that is expected to lead to an agreed treatment and the ongoing assessment of this as the optimal course. So depending on not just writing a prescription, but how otherwise I communicate with my patient, will decide whether and to what extent the outcome that I am expecting will be optimal or not. The treatment outcome, will depend on a very simple thing: whether the patient is following the advice that I have given. If I have prescribed medicines, whether the patient is consuming the medicines the manner I have prescribed. If I have also given some non-medication advices, whether the patient is following them up or patient is complying with them. So all these will decide only when the patient is actually following the instructions, okay, and cooperating with the healthcare professional. Then only one can expect that there could be some positive outcome, okay, if there is any. Can I have the next slide, please? There are huge, the literature is replete with huge statistics and huge data on medication adherence in diabetes care. We have mentioned about the simplicity or lack of complexity in the prescription, and here is one study in which they have shown that as when you compare between oral and insulin treatment, and even the oral treatment, again oral monotherapy or oral combination therapy, or insulin monotherapy, insulin combination therapy, and insulin plus oral treatment. And here you see that they have divided into high compliance, moderate compliance, and low compliance, and they have shown that percentage of patients that are coming up with high compliance with all treatment is 50%, as opposed to moderate compliance is 41% and low compliance is 9%. Okay, when you think of only oral treatment, oral monotherapy, it is 49%, as compared to oral combination. There the compliance rate increases a little, 49 to 50 only. Similarly, moderate compliance and is also a little more, and low compliance, monotherapy is 10 and oral treatment combination is 8. When you compare between oral and insulin, the compliance is a little better in insulin therapy, okay, but when you combine insulin and oral, the compliance is likely to be less. So right now Dr. Bhadury was discussing and highlighting the importance of adding the basal insulin therapy with oral therapy. Yes, it is based on hard evidence, and it is going to provide a much better treatment outcomes. But then it is also will have a challenge of the compromise with the compliance. So possibly the physician is to do a little more, go a few miles more to ensure that the compliance is not compromised. So insulin and oral treatment, when we combine, there is a possibility uh, of compromised adherence, okay, as compared to only insulin or only oral therapy. So this is to be kept in mind. Next, please. Next slide. Yes, this is the in general, not just specific to diabetes therapy, but the 5 dimensions of adherence, as has been propounded by World Health Organization, adherence to long-term therapies and the evidence for action. So these are the 5 factors. So whether it is the attributes of poor adherence or attributes of good adherence, that relates to the condition and or the disease, okay, the therapy that is given for the disease, the patient related factors, the social and the economic factors, and the health system and the healthcare team factors. So all these are otherwise applicable very specifically or very aptly in diabetes management. Can I have the next slide? Next slide. Yes. So this is a very good study, in a very recent one, this year only, and they have shown that in adherence in diabetes, all these 5 or rather 6 different factors, okay, as has been otherwise propounded by World Health Organization. So they have tried to analyze the adherence issue in diabetics in terms of all these 5 or 6 factors, and they have also found out the factors that may be responsible for decreasing adherence and how the adherence can be improved, what factors actually lead to improvement of adherence. So whether it is socio-economic related factors, they have also thought of the therapy related factors. Here you see that complexity of the treatment decreases adherence, while less frequent dose or monotherapy with simple dosing schedules and frequency of self-care behavior, so that actually improves adherence. Healthcare team or health system related factors like poor relationship, less communication between the patient and the physician, all these will have adverse impact on the adherence. Socioeconomic related factors, the cost of care decreases adherence. The some of the uh, host factors like age of the patient, more than 25 years, and older adolescents. So all these factors, they actually tend to decrease adherence. On the other hand, the younger adolescents, the male people, and the adherence to physical activity is better in male, adherence to diet is better in female, social support and family support definitely will improve adherence, etc. So some of the condition related factors, like if there is comorbidities like depression or frailty syndrome, etc., and also the duration of the disease, all these will have a negative impact on adherence. Internal resources like life satisfaction, acceptance of illness, so all these will improve the adherence. Patient related factors like stress, emotional problems, etc., will decrease adherence, while positive self esteem and self efficacy, they increase adherence. So while we are treating our patients of diabetes, we should keep all these in mind, and we should try to ensure that how we can also do what additional activity we should engage ourselves in, so that the adherence could be improved in a given patient, in an individual patient. Next, please. So this was some of the people have also tried different kinds of interventions for improving adherence, and as we mentioned that these are the 3 major modalities in treating diabetics. Of course, medication is important, but then diet and exercise are also equally important, and there were mean changes in the intervention group on medication, diet, and exercise was looked into at 3 weeks. So the blue ones are the baseline, and the red one is the post-intervention. You see how there is improvement in adherence. Percentage of patients who having adherence was baseline was around little less than 60, but after intervention it has increased to almost a little less than 100%. This is with the medication. With diet also there has been improvement, but not as good as in case of medications, and with exercise it is still less. But then it has shown that with intervention one can definitely have a good impact on improvement of the adherence. The question is, there it can also have a decay effect. So there should be also whatever intervention we can think of, okay, so that also has to be done in a continued fashion, otherwise it will have a decaying effect. Next please. The different types of interventions also have been suggested. This is another work, okay, which has tried to identify the barriers and solutions in diabetes management, and specific barriers they have identified, and they have also suggested the solutions. Because of scarcity of time, I'm not going to discuss in greater detail, but the broad heads are relating to efficacy and safety of the treatment. That has a very great impact on the possibility of adherence, or on optimum adherence. Similarly, convenience of the dosing or the regimen and the lifestyle. This is another broad theme which otherwise determines the adherence. And third is about education. So these are the three broad heads under which we can consider our intervention plan, whereby we can try to improve adherence on a focused manner and in an individual setting, individual patient setting. Next please. This study was actually done in some of the diabetologists from this city. They also participated in this study. Now, these are some of the strategies in improving adherence. Of course, they are not in India. One is pharmacist interventions to improve medication adherence. The second is the medication adherence could be improved when practitioners are supported by skilled ancillary staff. This is very important, and I know personally that at least in Dr. Debasis Basu's clinic, so it's a very good team approach that they actually employ, and some of their support staff are really very good, and lot of time is actually devoted in trying to understand the each and individual patients, and importance of counseling. Okay, individual patient counseling is extremely important for improving adherence. So this study, the third one, is education and skills training and problem solving are the key components in intervention. One-to-one counseling was found to be effective, along with interventions led by other healthcare professionals, with pharmacists having more statistically significant results. So whether it is nurse counselor or a pharmacist or some other support staff, so there is a need to have a good team approach to improve adherence, and one need to try to find the specific host specific issues, and accordingly try to tailor the treatment so that we can expect a better adherence in a given patient. Next please. Next slide. Can you change the slide please? Yes. So I think this is the last slide, and I have tried to actually summarize that what we should do in reference to improving adherence in diabetes management. So I have tried to coin this. Actually, I have borrowed this phrase from some literature: matching adherence to patient behavior, meaning thereby every patient is different, and if there is an adherence issue, first of all we have to identify the magnitude, the presence of the adherence issue, and also the magnitude of the issue, and accordingly try to understand, find the cause for this non-adherence or suboptimal adherence. And most importantly, the first thing is, if a patient is not reaching the target glycemic control, the first thing is to rule out that there is no adherence problem. So If not otherwise categorically identified, one has to consider that there must be some adherence issue, and then try to identify what is that and what are the possible reasons for such suboptimal adherence, and try to fix that. So this slide is more or less a summary slide. Adherence in healthcare refers to the extent to which patients' behavior in taking medicines and or in following diet and lifestyle changes advice corresponds with agreed recommendations from care providers. It is it is the definition of adherence by World Health Organization. But then when you talk of agreed recommendations in Indian setting, to what extent it is really realistic or feasible or being practiced? Yes, it is important to have agreed recommendation. The more the agreed recommendations, the more the recommendations are agreed upon by the patient, the lesser is the chance of non-adherence or suboptimal adherence. But then this is a great challenge of getting the recommendations agreed by the patient. Okay, and here we have to struggle and we have to achieve a lot, and that possibly may not be possible only by the physician. So we need to have a team, and then only through this team approach with individual one-to-one counseling, that is we have to make the patient agree. And if there is an issue of non-agreement or issue involved, then we have to identify that, and until unless the patient agrees to what prescription is being given, we should take it for granted that it's not going to be adhered to. Only less than 50% of diabetics, only in less than 50%, the desired glycemic goals are achieved, and hence complications for diabetes would appear over time. This is associated with poor adherence to diabetes care, to oral hypoglycemic medications, 36 to 93%, to insulin, 62 to 64%, and to long-term exercise programs, 10 to 80%. So we need to understand this, and accordingly, each and every patient, we need to also, while working up on the patient, okay, on the biomedical aspect, we should also work up on the possibility of non-adherence in a given patient from the very start or onset of the treatment. When we are putting up the prescription for the first time in a given patient, we need to understand the patient and accordingly try to minimize the possibility of non-adherence or suboptimal adherence. And in each visit, we have to also reassess the possibility of non-adherence. Reason for non-adherence include age, information, perception and duration of disease, complexity of dosing regimen, polytherapy, psychological factors, safety and tolerability, and of course, cost or affordability. So the measures that can be considered for increasing therapy adherence in type 2 diabetes would include broadly reducing complexity of treatment regimen, most important, very important, customizing treatment to suit individual factors in each individual patients. So that is what is also can be considered as personalized medicine, precision medicine, whatever you can call it. Optimizing safety and tolerability of treatment, educational initiatives, improved provider communication and social support, and last but not the least, ensuring affordability. Okay, so these are the as a whole, we can say these broad themes or sub themes are to be considered in all our attempts towards measuring adherence and also uh, trying to intervene in order to improve or optimize adherence. I think that is the last slide. Can I have the last slide? Yes. What was true in the Hippocratic era? Hippocrates was the first to note in 400 BC that some patients did not take their medications as prescribed and later complained that their treatment did not help. But then it is only 1985, the Surgeon General, United States Surgeon General Everell Koop had said drugs don't work in patients who don't take them. So it is as simple as that. So all of us should try, all the healthcare professionals and the healthcare system should ensure that the patients, not just drugs and non-drugs that are otherwise prescribed for treatment, they will, in order to make them work, we need to ensure that people for whom they are prescribed, they are taking them, or they are otherwise adhering to the treatment that is prescribed. So with this, thank you very much, and I don't know whether there is time for any further discussion. I now hand over to Dr. Shambo Samajdar. Thank you.
Thank you, sir. Thank you once again. You had mesmerized us with this topic, and actually, this is one of the most important thing. We talk about costly drugs. We talk about different difficult uh, interventions, but what we forget that a simple measure, by remembering how to take regular medicine, that can improve uh, a much in the terms of outcome. So thank you, sir. Thank you once again for this wonderful talk. And I think it is 11 now. We should not stand between the dinner and uh, our respected delegates. So may I request Rohan to have some concluding remarks. Mr. Rohan Tripathi, who is the director of Inovocare Healthsoft Solutions, is working wonderfully, specifically in the sector of chronic disease management. And this chronic disease management and adherence is together, we can say, a very, very important thing. And he had prepared a wonderful device that increase adherence. May I request Rohan to say about something, what device you had prepared, and then we can wrap up today's session. Over to you,
Thank
Rohan.
Thank you so much, Dr. Samajdar Shamboda. As this series of webinars started, the main aim was to all it was mainly started with the motive of increasing awareness about medicinal adherence, in tune with our device MedpeR that we have almost we are developing still now. So when we had started with, the main aim was to increase adherence, but the amount of rich input that we have received from the experts through the last 7 months, not only have we are in a better place with data, but we are far more encouraged about the need of such a device. And another thing is, it's really alarming to see in this 2021 the entire country suffering through such a lack of adherence regarding medicines. So in one prospect, it increases my ambitions as the founder of a startup which is developing a device to answer this problem. It makes me even more ambitious, but in another term, it makes me a little scared about the current scenario, to be honest. Today was another such wonderful program that we had. All the speakers, starting from Dr. Samajdar, then Dr. Basu, then Dr. Bhadury, whom I personally apologize to for the miscommunication, for which there was a error for the from the miscommunication, and of course Dr. Tripathi for all their wonderful sessions. And this session was recorded, and the entire thing would also go on YouTube with everyone's permission. So with that, that is all from our part, and hopefully very soon we will be there in the market with MedpeR, or your personal medicinal helper, and that would be as many of our speakers all through the today and all through the last 8 episodes, they have repeated a single line, that is, we need to come together and discuss about a solid consolidated effort to answer these adherence issues. So I think MedpeR would be a very good step forward in that regard. And I hope that in the days to come, we will be much better equipped to answer this problem. So thank you, and over to Dr. Shamajda. Thank you so much.
Thank you.
Thank you very much. One thing is important to just remind you via this medium, that because there are lots of requests are coming regarding one book, because you are organizing a fantastic seminars every month. So please look after that matter. We need one book at the end of 12 months journey. So adherence is a very important area for our management or in medicine practice. So we need this book, which would be a we can say phenomenal in this field. So please look after that. With guidance of Sir Tripathi Sir, we most probably will get some success making this book available by next year. What is your take on that?
We should definitely work on it. We have so much content available from the last 7 months, and hopefully, we will have even better content, even richer content available by the time our 12-month mission is over. So, by then, I hope we would be, because we are trying to cover almost all related topics relating to adherence. So by the end of the 12-month journey, we should be in a position to have a very content-rich journal. So with all, if all of you really want it, and I promise to work the best of my abilities to make it happen. It will only happen with your guidance and support. Thank you.
Let's hope for the best. Let's see.
Yeah.
Thank you. Thank you very much.
Thank you.
Thank
Good
you.
night.
Good
Good
night,
night.
everyone.
Good night.
Good night.